Okay, once again, I'd like to welcome everybody to our Incident to Services webinar. Today is the Study Hall Incident to Services. This is the first in a two-part series on Incident to Services. Today is Study Hall. So today we are going to be going through all of the basics and provide some examples on Incident to Services, that core information. Tomorrow, Ashley will be doing our pop quiz, which is going to cover denials and how to pass those. She's going to give you some tips and tricks. She's going to talk about those most common denials. And I did mention it's going to be a pop quiz. This is going to be an interactive session. We are going to ask you to respond to some questions for us to help you apply the knowledge that you've learned today and that you'll also gain by attending Ashley's session tomorrow. Now, for those of you that maybe were not aware of that second session or haven't had the opportunity to register for that, registration is still available and it's available up until our session tomorrow. So I've also asked Ashley to put the registration link in the chat for you if that is something you're interested in. As I said, I encourage you to take part in that. The two sessions do work together, and tomorrow you are going to have that opportunity to apply what you've learned today. Just a couple of quick housekeeping items before we get started with our material today. Training material. I am sharing with you a slide deck that is available as training material on our live events page. Ashley's going to include a link to that in the chat. We'll look for the title of today's events, which will be one of the top few webinars that we have. And you will be able to see the link for training materials. And that, again, is going to download that PowerPoint presentation for today. Also, as I mentioned, today is being recorded, so barring any technical issues, this session will be available for 60 to 90 days on our Encore Presentations page of our training center. So if you want to see anything again, have any questions, or feel this would be helpful to someone who was unable to attend today, you'll be able to send them there. We are handling questions through the chat today. We did receive quite a few excellent pre-submitted questions today that I've incorporated into the material. So hopefully we are addressing all of your questions today, and you may think of some more. I encourage those questions, so please throw those in the chat as you have them. I don't want anyone to forget their questions as they have them. I will be checking in with Ashley to answer those questions. If for some reason there are more questions than time allows for today, don't worry, I have you covered. I'll be creating a follow-up document that will be covering those questions. Additionally, Ashley and I will work to incorporate those into the session tomorrow. Also, at the end of this session, we will be providing you the opportunity to provide us with a little bit of feedback on how we did today in our session. I know in our daily lives we are bombarded with surveys and sometimes you go a little bit blind to it, but I would really appreciate it if you would take just a little bit of time to tell me how I did today. We want to make sure that we continue to do and offer the education that's helpful to you, but we also want to make sure that if something's not working, if you're needing something different, that we're doing that as well. So please give us a few minutes of your time and provide us with some feedback so we can make sure we're providing you the best possible experience. Also, this is an opportunity for you to provide us feedback on topics you'd like to see in the future that may not have anything to do with Incident to Services. We do look at those and we do plan our education based on that. This is our standard disclaimer, just indicating that today's session is current and accurate as of today. If you've worked with Medicare for any period of time, you know that Medicare rules change and change often, so please make sure that you're continuing to monitor both CMS and WPS websites just to make sure you're following the current rules and regulations. Also, recording, photographing, or screenshotting this education for profit-making purposes is strictly prohibited by CMS. And as I mentioned earlier, we are recording this session, so you will have that available to you. These next two disclaimers are just for the CPT and the American Hospital Association, and they are just stating that we will be, the descriptions of the codes that I will be displaying for you today are not owned by WPS and that they did not have input in the creation of today's education. I will be using several acronyms today, so I have included that in the training material for you should you find that helpful. Okay, housekeeping taken care of. Thank you for your patience. That brings us to our objective for today. What are we going to talk about today? So today we're going to talk about how and when you can bill for services when they are provided by someone other than that billing practitioner, incident to that billing practitioner services. So the objective for today is to provide you with that understanding of incident to policy and those billing requirements. Basically, incident to is going to allow a billing practitioner that to submit and be paid for claims for services that are provided by someone else. So we are going to cover incident to guidelines to help you identify when this can be done. We're also going to talk about incident to billing guidelines. So how are you going to bill for those services? And we also received quite a few questions on the documentation. A lot of the documentation for incident to is not dissimilar from normal documentation guidelines, but we are going to call out a few situations that are specific to incident to that we received questions on. So we'll start with an overview of incident to. Like I said, incident to, very basic and simply defined, is a service that's provided by somebody else other than the billing practitioner. There's going to be a billing practitioner that is going to submit those claims, and these services are typically included in the diagnosis and treatment of that patient. They're services that are part of that billing provider's treatment plan. They are integral to the diagnosis and treatment of that patient, but they're considered incidental to that encounter. So incident to services, they can be part of a physician or a non-physician practitioner and MPP services, and they can be performed by ancillary or auxiliary staff. And if an MD or DO is the billing provider, it could be that MPP or that ancillary or auxiliary staff that's providing that service. These are going to be, I'm going to stop there just one second. One of the pre-submitted questions that we did get was to define what the ancillary auxiliary staff or those MPPs that are eligible to bill for that incident to. So the non-physician practitioners that we'll typically see, they're going to be providers that are licensed by the states that they practice, and they're providing services that are inside the state's scope of practice for that. And that's kind of a really important piece because every state can be a little bit different. I have a background in provider enrollment, and all the licensure is a little bit different with the various states. So you want to make sure that the services that they're providing are inside their scope of practice and something that they're able to do in their state. So some examples are going to include nurse midwives, clinical psychologists, clinical social workers, obviously physician assistants and nurse practitioners, clinical nurse specialists, and then your auxiliary staff may include nurses, may include medical assistants. It could be licensed or certified health professionals. Again, we've got to look at that scope of practice, but those are the type of providers that we will be included and eligible for that incident to billing. So when we're talking about those MPPs, though, you want to keep in mind that those MPPs are eligible to enroll and bill for services directly, and they can provide services without supervision. So when we're talking about those MPPs, we're looking for them to be enrolled because, again, they're eligible to bill directly. However, if their services are being provided incident to the billing provider who happens to be an MD or a DO service, they could be billed incident to the physician. But incident to is not something that's going to preclude those non-physician practitioners from enrolling in Medicare. It's just there's going to be some situations where they will bill. The other thing that I want to call out is these services, when we're talking about incident to, we're talking about services that must be provided in a non-institutional setting. So typically office services. We'll talk about place of service just a little bit later to get in a little bit more depth, but typically we're talking about non-institutional settings. For an institutional setting or facility setting, Medicare does allow for something called split shared services to be billed. Ashley's and I are going to be covering that in a webinar series set up similar to this, where we have our part 1 study hall and we have our part 2 to have hop quiz, which is that interactive session to help you apply that knowledge. That is happening next week. I just want to call that out. If I have anybody interested in split shared services, we will be having that webinar next week, and Ashley has thrown out registration links for those. Again, they're available up until the session time, and they're going to be held on September 23rd and September 24th. If anyone is interested in that, you have that. So we've received a couple of questions regarding modifiers, and specifically the FS modifier. That's not a modifier that's going to come into play here. That's going to be split shared, and we'll talk about that more next week. But modifiers are not required when billing for Incident to services. Medicare does not use any type of modifier to indicate the services were provided in Incident to, but documentation is going to need to support those services were provided as Incident to if that is reviewed. We'll talk about documentation a little later on. We did get quite a few questions on documentation, so hopefully we'll be able to assist you with that today, but just bear that in mind. Incident to is also not all-encompassing for all services. One of the things that you need to be aware of is if the service being provided has its own benefit category. And we'll show you some examples here in a minute. But for services with their own benefit category, they do need to meet the requirements for that benefit category. And that can be different. And they may not be able to be billed. One other thing I should have mentioned earlier that I believe Ashley's already put into the chat for you. One thing I want to call out is we are not going to be covering Incident to for mental health services today. That is actually a webinar in and of itself because there are differences between the typical Incident to guidelines and behavioral health guidelines. But I also did not want to leave those that had asked about that. I didn't want to leave you without any information. So a few minutes ago, Ashley did throw in the chat an encore for Part B mental health Incident to services. Ashley, I'm going to ask you to throw that in the chat one more time so people have that. But I just want to make sure everybody was aware of that as we're going through this. So benefit category restrictions. I want to talk about that just a little bit more so that we can talk about why they're not eligible for Incident to. So Incident to does not apply for items of services with their own benefit category because they've got to meet the requirements for that particular service. The supervision requirements could be different. We'll talk about supervision for Incident to, but those requirements could be different based on their benefit category. There may be, depending on what the service is, there may be different supervision levels. That supervision could include being direct supervision, general supervision, or direct personal supervision. And so there are many codes that you want to make sure that you're looking at because if they have a separate benefit category, they're not eligible for Incident to and they need to be billed on their own. There are also quite a few codes that state specifically that it's a physician service or it's a physician and or other qualified healthcare practitioner. So this could mean that it's only billable by an MD or DO, or it could also include that non-physician practitioner. But when it says that, it may not include or be billable when it's provided by the ancillary staff. So you want to make sure that you're checking the CPT for the services that you're billing to make sure that you're following those guidelines. Again, this is typically when there's a separate benefit category. You also want to make sure that you're looking at CMS guidelines to see whether the service can be allowed as Incident to. Sometimes CPT and Medicare are not in agreement, so you do need to use the two in conjunction just to make sure that you're following the proper guidelines and avoiding any unnecessary processing delays or denials. Additionally, sometimes CMS is, oh, sorry, already went there. We just want to make sure that you're aware of following both CPT and the CMS guidelines for those services. So what are some of those benefit categories? So for example, radiology. You could have a chest x-ray that has rules specific to who can bill for that and what supervision level that is. There's other radiological tests that you're going to want to look at. Also, when you get into radiology, there's going to be the technical component and there's going to be the professional component. The technical component, because it's that test, it's going to have its own benefit category. Now, the incident 2 component could maybe be billed incident 2, but it also, you want to make sure it's not being separately billed. Laboratory pathology, this is also a separate service. Now, these are tests that would support the medical decision making, but it is billed separately from that professional service, and it does need to be billed that way versus incident 2 service. You'll also see that I have vaccines included here, and these have their own benefit category, and they have a service that is billed that encompasses the entire vaccine. Those are not going to be billed incident 2. There's a separate category and a payment structure for that. With antigens, you may run into situations where incident 2 guidelines may apply, but typically those antigens are going to have specific rules, and you need to make sure you're checking CPT and CMS guidelines to make sure that you're billing it correctly. So here are the requirements for services to be covered under incident 2. We have talked about some of this, but I wanted to lay them out here. So first and foremost, the service has to be an integral part to the provider's service, and that billing provider needs to be assessing the patient and determining what needs to happen for that patient. So they're going to be creating a plan of care, and the individuals that are providing the incident 2 services are following that plan of care. So one of the requirements is that the service is part of the billing provider's services as normal course of treatment. It needs to be something that is going to be commonly rendered without charge, or it's included as part of that professional service. So remember, the billing practitioner here, so if that's the MD, DO, maybe it's the MPP, is going to be the one billing for the service. That's the provider number that you're billing the service under. So it's typically something that would be included if billed by that billing practitioner, but it's being provided by someone other than that billing practitioner. As I mentioned, this is going to be for non-facility settings, so we're looking at services that are commonly furnished in that physician's office. The other thing is that that billing practitioner, the one that is creating that plan of care, they need to maintain their involvement with the patient care. So this isn't going to be a situation where that billing provider sees them and then hands off 100% of their care to whomever is providing those services. That billing provider still needs to oversee that plan of care. If changes are made to that plan of care, that billing provider needs to be involved in that. We'll talk about some oh by the way situations a little bit later, but that is really a key piece that billing practitioner needs to maintain that involvement. We're billing under that billing practitioner's number, so whether it's an MDO-DO that has the MPP billing or providing the services, or in the case of the MDDO or the MPP being the billing provider, the ancillary staff is providing the services, we're billing under that billing provider's number, and the payment structure is going to be a little different. So they need to remain involved in that care. So some of the questions that we'll get with this, one is we'll see questions about a patient that's transferred to the MPP and they're continuing to bill as incident 2. If that care is being transferred to that nurse practitioner, then this is not appropriate. You're not going to bill incident 2 for the patient's care, because at that point they've been transferred and that physician is in that scenario not remaining involved in the patient's care. Okay, so again, that main provider needs to maintain that connection, that involvement. The other thing with incident 2 requirements, it does require direct supervision. Now, what exactly does direct supervision mean in this case? So let's talk about that a little bit. So This means that whomever is performing the incident to service, be it the MPP or the auxiliary staff, they're doing so under the direct supervision of the billing provider. So again, that could be the MDDO or a qualified MPP, but whomever's doing the service is providing them based on the billing provider's plan of care, and they need direct supervision. That billing provider needs to be available for immediate assistance should they need to step in. So this means they need to be available at once, like now, not later, not we'll text them and they'll get back to us. There needs to, we can't have any intervening time. They need to be able to take over if they need to. We once had a medical director that referred to this as being within speaking loudly distance. So immediately available again. So this could be they're in the room. They could be in the office suite. We do have right now in place where real-time audio-visual telecommunication is allowed through December of this year. I want to spend a little bit of time on that. That is an exception. That is not typical, but it was part of the 2025 final rule and it was extended until December 31st. But again, it's not a chat. It's I can call them, we can do a video chat, that kind of thing, but they are immediately available, not the next day or in a few hours. Like I said, immediately available. We need you now. That is available through the end of the year. I have looked at the 2026 proposed rule, and it looks like they are considering making that permanent, but we're not going to know that until the final rule is published later this year, probably November. So we'll need to keep an eye on that. But right now, this is a viable option for that direct supervision. But stay tuned. We do have to look and see what CMS does. The other thing is the billing physician may not see the patient on the same day as the incident to services, as long as it's part of the billing provider's plan of care. Again, that billing provider is responsible for overseeing the care of that patient. So it could be that they come in today and they're seeing the nurse practitioner, or they're coming in and seeing that ancillary or auxiliary staff. They don't see the provider, but they are following the plan of care that is set by that billing practitioner. As long as they're following that plan of care, they can bill for incident to. The other requirement for billing incident to is there must be an employment relationship between the person providing the service and the billing provider. So it means that it could be that they're employed by the same clinic. So you have the person that's providing the service and the billing provider, they're both employed by the same entities. So for example, we've got ABC Medical Clinic employs both the physician and the clinical staff. That's an employment arrangement. Even if that clinical staff isn't necessarily working directly for that physician, they work for the same clinic. That is acceptable. They also could be a direct W-2 employee or a direct employee of that billing provider. You could also have a contracted employee. Now, typically you find those, they have a contract, maybe there's a 1099, maybe there's a staffing agreement between the billing provider and the staff that's providing the service. That's what we're looking for, that contracted employee. The other item that would constitute an employment arrangement is a leased employee. We get questions on what a leased employee means. So it means that an employment relationship that is recognized by wherever you happen to be practicing, so applicable state law, and it is established by a contract, and you're going to need to have where you may have, how do I want to say this? We have seen situations where providers are contracting, you might have a cardiologist that is contracting with nursing staff. So that could be something that constitutes that leased employment arrangement. It just depends on how that contract is set up. One thing though, you do need to be able to supply that agreement, and it does need to be signed and acknowledged by both parties. It has to show that arrangement. It's got to show who's providing what services. It also has to show how reimbursement is working a little bit. So we have to see that in that contract, should Medicare request it. It doesn't come in with a claim, it's if Medicare requests it. And then the other thing is that the services that are provided, they do have to represent an expense to the billing provider in order for the billing provider to bill for those services. As I said, these are services that are part of that treatment. So they're services that the billing provider may themselves provide. They have to represent that expense. So I keep talking about this plan of care. So let's look at that a little bit more. The plan of care does need to be in place, and it is what that billing practitioner has determined are the needs and outcomes for that patient. Now, a question that we do get, and I just want to call out, this is something that is going to be established in, maybe it's in a previous visit. So you're not going to start out, say it's the first time you're seeing a patient, you're not going to start out with Incident 2 services because that plan of care hasn't been established. If there is a new diagnosis, that's not necessarily going to be, or that's not going to be part of a plan of care necessarily if it comes up in that service where that you're wanting to bill for Incident 2, and we'll talk about that a little bit. But that billing provider is going to need to perform that initial service, and then, as I've been saying, they have to remain actively involved in the patient's care, their treatment, what are their goals, and they need to have that outlined clearly so that the ancillary staff or whomever is providing the services as Incident 2 can carry out that care plan. So it's going to need to include the conditions that are being treated or the diagnosis. It's going to need to include treatment options that are available. It's going to need to tell us which ones are being followed. Are there any interventions planned? It does need to be clearly laid out. And again, that the rendering staff are carrying out that plan of care. They're not making adjustments. So for example, you have a patient who is diabetic and the billing provider wants the patient to be seen every 6 months to have their glucose level and A1C checked. So say the NP is going to provide that service, the MPP has to follow the plan that was outlined by the billing provider in order for it to be billed under Incident 2 guidelines. Okay, it does need to call out that the practitioner remains involved in that care, and we'll talk about documentation for that a little bit more. But if we're reviewing that, it does need to clearly outline what was done and how that was part of that plan of care. One thing I do want to call out as well, these are questions that we do receive. We get questions about how often the billing provider would need to see the patient. So there's no information that CMS has published that outlines that. But again, it's showing that involvement. So there's not, they have to be seen every 30 days. They have to be seen every third visit. That's not outlined. You just have to show how you're remaining actively involved in that plan of care. Another question that we received, we actually got this as part of the pre-submitted questions. What if the MPP changes the plan of care? So the service is no longer Incident 2 in that case. I mentioned that where that billing provider has to be involved in that plan of care and those that are rendering have to follow that. So the MPP carried out the plan of care for the visit, but maybe this is another situation. They carried out the plan of care for the visit, but as that MPP is leaving, they get the oh by the ways. They came in for their A1C and their glucose check for the diabetes, for the example that they gave. They followed the plan of care, and as that rendering person is leaving, the patient says, oh, by the way, I have a rash on my elbow. So at that point, that service is no longer Incident 2. They came in for diabetes. The rash on the elbow is no longer part of the plan of care. So in that instance, the service is going to be billed by the NPP because that entire service is not Incident 2. So that's something to keep in mind. That does happen. Another question that we get, the MD or DO involved in the patient care retires or leaves the practice, and the MPP is now the billing provider. That's what happens if they leave. So if you have a physician and an MPP, you've been billing for the MPP as incident 2, that physician retires, leaves that practice, that MPP is now that billing provider. If it switches to another billing provider, well, you're going to have to set up that plan of care and they can follow that incident too. So those are things you need to things you're going to have to think about and things that are going to have to be supported. Especially if that provider is leaving, you no longer have that billing provider in your office. Another pre-submitted question that we received on this, can the MD document that medication strength can be changed in the treatment plan and the MPP change it and support incident 2? The answer to that is no, because that is a change to the original plan. That plan of care needs to be very specific. And that decision about that plan of care, that change, does need to be made by the billing provider in order for it to be billed as incident 2. That wouldn't be enough because it wouldn't lay out necessarily what that medication change is. Again, that documentation has to support that the original plan of care that was set up by the billing provider is being followed by the rendering staff. So next we're going to look at billing requirements. So when we're talking about incident 2, again, we're talking about the non-institutional settings. And so services can be provided in place of service 11, which is going to be your office, nursing facility, which is 32. And we get questions on that. This is not a skilled nursing facility. So a skilled nursing facility is ineligible for incident 2, but a nursing facility, you're in a Part B stay versus a Part A stay, that is considered a non-institutional setting for incident 2. So that could happen. Also, patient's home or place of service 12 is eligible for incident 2 services, but there are specific circumstances to that, and we will talk about those in a minute. Place of service that are ineligible for incident 2 are place of service, as you can see, 21 for inpatient, outpatient hospital, which was 19, 22, and 23, skilled nursing facility that I just mentioned, and the nursing facility, I apologize, that should have been deleted. That is on me. I apologize, everybody. We did receive a pre-submitted question on this where they were asking if there are different services specific to the place of service. And the answer to that is no. The place of service needs to reflect where the services were provided, but it's not going to change the services that can be provided. So these are examples of professional services that could be billed incident 2. So first and foremost, E&M services. So those office visits. Unless the person that's providing the service is enrolled in Medicare and they can bill an E&M service. They cannot bill a higher level of service and they kind of have to stay on that 99211, especially the ancillary staff. So you're billing incident 2 services, again, that ancillary staff is going to use the 99211. Now, when you have an MD and a DO and an MPP, they're both going to be likely enrolled, and they do both need to be eligible for that service. But again, if they're not enrolled, they're considered ancillary staff. So you're only going to be able to go to that 99211. So keep that in mind. So some examples of that, we do get questions about that. You have a PharmD, so you have a doctor of pharmacology. So they would fall into this category. They would bill that 99211. We've seen this question before. The code is an E&M code, but it's limited. That PharmD is not enrolled in Medicare. So that would be an example of someone that has that licensure, has that level of certification, but they're still going to bill that 99211. Another example would be a blood pressure check. So while this is not an incident 2 service on its own, it's not, but if they're using that to evaluate and manage the patient, that blood pressure check could be billed But again, if it's that ancillary staff, it's going to be that 99211, as long as all of the other incident 2 requirements are met. Some other professional services that are eligible for Incident 2 include the administration of drugs and biologicals, and the cost of the drugs are part of this is that administration fee. There are certain minor surgery that's generally going to be your MPP, not your ancillary staff in most cases, but it's also based on your plan of care. And if it's not in the scope of practice for the provider performing it, it's not going to be something that can happen. The last one is the reading of x-ray results. Now, I mentioned x-rays may have their own benefit category, and remember we talked about that technical and that professional component. So that technical component is still going to be billed separately as part of the test itself. But that professional component, if there's an independent interpretation or if there's an interpretation that's being performed by the provider versus part of the test, potentially it could be billed Incident 2, but it can't be billed separately. You can't bill it twice. So you can have situations where the practitioner has a specifically designated space as their office located in a facility. That does happen. This space is an office and not the facility because again, it's designated as their office. It may be inside a bigger campus, but it's not considered part of the facility. So when that happens, services provided in the office setting are billing with the office place of service and the office procedure code. So look at how you're billing that. Staff that are employed by the physician, and remember we have to have that employment arrangement, can provide Incident 2 services in the specifically designated space. So they're providing the services in that office that's been designated that's not part of that facility, that place of service, that office place of service. Any services that they would provide outside of the designated area would be the facility place of service and procedure codes, and depending on that facility, there's a lot of scenarios that can happen. They may not be eligible for the Incident 2. They might start falling under an incident split shared situation there. But so you want to make sure that you're looking at that. Next, we're going to talk about home services. So Incident 2 services can be provided in a patient's home. Typically, an example of this would be when both the provider and the MPP or the ancillary staff are going to the patient's home together. So for instance, you have them going to the patient's home to see them, and that MPP or ancillary staff will give them an injection, and that billing practitioner would bill for that service. That's kind of an example of that. Now there's an exception to this because one of the things you have to make sure is that the patient is meeting homebound requirements. So those homebound requirements, there's information included in the resources section of this presentation. So those are going to be included for you today. But the patient has to be homebound and meet the criteria. So that means that patient can leave the home, but it's infrequent. It's going to be for relatively short periods of time. And it's a real challenge for them to do so. So it's not just a quick hop in the car and go. This isn't, they just don't leave home. They really have a challenge getting out of the house. We're not like I said, we're not covering those requirements in great detail, but I did include a link. And the link is to the Medicare Benefit Policy Manual, Chapter 7, and it's going to be section 30.1.1, and it outlines the criteria for homebound so that you have that list for you should you need that. The other thing is if they are going into the patient's home without that practitioner or with any services need to be medically necessary for that patient. So you want to make sure that the services are necessary. They're needed for that patient's treatment plan, their care plan. They have to be integral to the patient's treatment and care plan, making sure that they will meet those criteria for coverage. And they have to meet the normal Incident 2 guidelines as well. For homebound patients, the supervision is just a little bit different. It's general supervision, especially when you have the rendering person, whether that's the MPP or ancillary staff going to the patient's home, is general supervision. So we're no longer in the speaking loudly distance or the immediately available. It's a little bit different. So make sure you're cognizant of that. Again, these services are something that would be included in the practitioner's charges. And the patient is not being treated by a local home health agency. So I want to talk about that a little bit. The documentation is going to have to support that either there's not an HHA in the area to provide the services in the patient's home, or that the HHA is telling you they cannot provide the services for whatever reason. There's probably, there are a lot of situations for that. And so basically, this is saying the patient would not be under the home health agency's care, and that's why you're going into the patient's home. I do also want to qualify that or call out that RHCs and FQHCs do qualify to use these guidelines. So the types of services that this might encompass, it may not be everyday E&M services, but it could be things like injections. It could be a venipuncture. Maybe there's dressing changes. They just had a procedure. Maybe they're teaching and training the patient for certain situations based on their condition. That all could vary. It is not an all-inclusive list. So again, documentation has to support. So I want to talk about a second for drugs and biological. This is covered in more detail in Chapter 15, Section 50.3 of the manuals, and I have included a link to that in your resources section. So Incident 2 can be used to bill for the time that's involved when the patient's in the office. You can't submit for time for administration once the patient leaves the office. These are going to be services that are provided by the ancillary staff, and they're generally going to include things like providing those injections. Maybe they're starting the port. Maybe they're starting an external pump, things of that nature. And again, in order to bill for the drug, it has to represent an expense to the practice, meaning that practice has purchased the drug. Here, there is an exception for allergy and immunotherapy. So the exception to the rule here is about the billing practitioner being the treating practitioner. That is typically the case. Obviously, Incident 2 is going to have those MPPs and those auxiliary staff that are providing the service. But typically with Incident 2, the billing practitioner also has to be that treating practitioner that is maintaining that oversight in the care. For allergy and immunotherapy, it's a little bit different. Here, the billing practitioner for administering the allergy injections does not need to be treating the patient for the allergy. In this case, they have an allergist that is treating the patient for the allergy, and the allergist determines the treatment for that allergy. So an example, let's say you have a patient that goes to an allergist in another clinic, and maybe that's 2-3 hours away from their home. Based on that travel time, the allergist is determining, the allergist is still determining which allergens they need to treat that patient, but so they're determining the dosage, the frequency, all of that good stuff. But as I stated, it's a 2 or 3 hour drive. So based on that, the patient doesn't live near the allergist to get the injections, and they can take that information is then taken or sent to the regular practitioner, and that practitioner can submit for their clinical staff to administer the injection. So it's easier for them to get that. They may prepare the antigen. Again, the treatment plan is being laid out by the allergist, but their regular office is providing it. And if they're preparing that antigen, say that allergist is preparing that antigen and they're supplying it to that local practitioner, there is a code that can be billed, and it's 95165, and that's a physician supervision of the preparation of that antigen. It just shows that if you look at CPT, it just shows in the description that someone else has prepared that antigen. So that's something to keep in mind. So again, that injection of the antigen in this situation can be provided by the clinical staff of that local physician, but the services do have to meet all of the rest of the incident to guidelines, other than the billing practitioner being the treating practitioner, because that's the allergist in this case. I did call this out a little bit, but I did include it here as well. Medicare does cover Incident to services for rural health clinics, RFQHCs, and cause when they're billing those professional services. It's not, they're billing it more like those offices services. However, their services for Incident to are going to be submitted just a little bit different. So providers that are submitting on a 1500 or an 837P, these can be separate charges. For providers that are submitting on a UB04 or an 837I, these are not reported separately, but they are going to be included in your cost report. So that is something to keep in mind for my rural healthcare providers. Sorry, that went. So next is documentation requirements. Apologize, that screen auto advanced. So as I've mentioned, we have received quite a few questions regarding this one. So what the questions we're getting are, what does the documentation look like? What information has to be in there? So the documentation needs to include and clearly identify the person that's providing the service. So this isn't going to necessarily be the billing practitioner. It's going to be the person that's rendering that service. One specific question that we received, are there any documentation requirements for referencing the physician's plan of care in the mid-levels documentation? You do need to be clear about who provided the service, because when a reviewer looks at that, that's how they're going to identify that this was an Incident to service. So if the billing provider didn't perform the service, that needs to be called out in that documentation. Now, CMS has not provided specific verbiage or templates for how this documentation looks. That's going to be a business decision. But as we go through this, we'll talk through a couple of things. The next thing that needs to be included in that documentation is going to be the billing practitioner's availability. Remember, we've been talking that Incident to requires direct supervision. So you're going to need to be able to show in that documentation and support how that was provided. Were they immediately available? How were they immediately available? Were they in the room? Were they in the office suite? Were they maybe at this time, because it's allowed, was it audio visual telecommunication? How was that provider, that billing provider, going to be able to step in if needed? Maybe something goes wrong, there's questions, maybe something's got to change on that care plan. How were they available? This is going to be different for every office, so that's going to be a business decision for you, but you'll need to show that in that documentation. The other thing that needs to be included, we need to see the plan of care from the billing practitioner. So we need to know what care plan is being carried out by the rendering provider. How was that care plan followed in that visit? What services were provided? And just making sure that you're showing how those are aligning with the plan of care. Remember, by the ways, if you're following the plan of care and now there's a new condition or a new complaint from the patient that's being treated, that's no longer Incident to, because it's not part of that original plan of care. We also need to see the continued involvement in treatment of the patient. So how is that provider being involved? Are they being consulted? Are they seeing them? But how is that billing provider continuing to be involved in the patient's care? Remember, I said if they transfer them to the nurse practitioner as the billing provider, that needs to be built into the nurse practitioner. That's no longer maintaining involvement because they've transitioned that care. But how is that billing practitioner continuing to be involved? Again, there aren't guidelines or templates that have been laid out for this. It is something that you'll have to determine how to best document. We also need to see that the services that were provided were within the scope of practice of the person that is rendering that services. So is this something that their certification, their state licensure, is it inside the scope of what that entity allows for that type of provider. As I mentioned earlier, uh, with a provider enrollment background, you see the very variations in scope of practice for the different types of providers. They may have the same credentials, but different states may allow different services for that same credential. And then, as with any Medicare services, those services do need to be reasonable and necessary for the patient. They do need to be medically necessary. That's true of any documentation or any service that you're providing. So that does need to be clearly outlined there as well. So here you're going to see the resources that I've provided for you today. We have the Social Security Act. Again, that's going to talk about that medical necessity. I did include a link to the CFR, which is 42410.26, and this provides information on services and supplies that can be provided incident to that professional service. So that's a good resource for you. I mentioned a couple of different benefit policy manuals. Some are specific to incident to, some are specific to, one specific to the home care, that's section 50. So there are some good resources for you to dig a little bit deeper into incident to based on what you have going on. CMS has an incident to services and supply website. I have included that. I also want to call out one of our services. There's a WPS Incident to Specialty Training page that we have available. And the easiest way to find that, you can go into the training center and go into the specialty training page, but I like to search if I'm in the right spot. So here, if you search by incident to, there is an entire guides and resources page that is dedicated to all things incident to. This includes not only resources that WPS has available, but it also includes information that CMS has out there for that. So you do have that available to a lot of good information out here. So with that, I know we're running tight on time, but I do want to check in to see if we have a minute for a couple of questions. Ashley, do we have any questions in the chat?
Hi, Leanne. We had just 2 questions that I was not able to get to. Let me scroll back up here. The first one is, does the physician need to sign the documentation if the RN performs a service and it meets all the incident to requirements and is billed under the physician's name? Leanne, did I lose you?
Yep, I was sure on mute. I'm just going to repeat that just to make sure you heard it. The physician would need to sign that documentation because that is showing that they're overseeing that care. Next question.
Right. And then we had just one more. Oh, I had a couple come in. We had one more that says, what about urgent care facilities? And I think that came in, Leanne, when you were talking about place of service and office in a facility.
Yep, it's going to need to be specific to those office place of service. That urgent care, if it's in that hospital, it's going to be part of that facility. So it depends on how that's billing and what place of service they're using to bill that.
We did have just one more come in if we have time for it.
Sure.
This one is assisted living considered homebound since they use the same place of service?
So this one, the assisted living typically is not counted as a patient's home. They are living there, but it's not necessarily their home. It depends if it's considered a medical facility.
All right, that was our last question.
Okay. So, in a couple of minutes, you are going to receive an email to thank you for attending. Don't delete that. You want to take a look at that. If you're attending for continuing education credits, this is going to be your certificate of achievement that you can submit to your accreditation or certification body. You'll see it has a couple of things. It does have a link to our survey, and then it also does have your contact hours and your date towards the bottom. If you didn't get this, either it went to your junk or spam folder because it's not on your safe sender list because it comes from our webinar software, or you attended by phone. If that happened, that is okay. Just send an email to the education mailbox. Ashley's going to throw that in the chat in a few minutes. And let me know that you attended, you need a certificate, and also include the phone number that you attended from so that I can confirm your attendance and then go ahead and get that certificate out to you. If you have any follow-up questions, I know we covered a lot today, and if you're anything like me, the questions will come to you at 2 in the morning, and hey, wished I'd have asked this. I am going to take questions for the next 7 days. Send those to our education mailbox and throw the subject line, which is today's topic. So study hall, incident to services, even incident to services will get that to me. However, I've made it super easy. If you've downloaded the training material, click on the link in that material. It'll pop up an email. It already has that populated for you. I do just want to call out though, if it's specific to a claim that's in process or you have an appeal, those do need to go to customer service because they'll have access to that. As I mentioned in the beginning of the session, we know everyone asks you to take a survey and you can kind of go blind to that, but this really is our feedback loop. This is our direct communication with you, and I'd really appreciate it if you took a couple of minutes to provide me with a little bit of feedback. Tell us what we did well, tell us what you'd like to see in the future. We certainly look at all of that to evolve our education and make sure we continue to provide education that you're finding useful. Also, topics that maybe had nothing to do with incident to services today. You can throw those in the chat. We look at those and we use those to plan our future education. So you are truly heard through these surveys. Again, I appreciate your time for that. You're going to have a couple of ways to do that. It's personal preference. Ashley's thrown a link in the chat. Click on that. It'll take you to the Qualtrics survey. The other thing that's going to happen when you leave our webinar software, you are going to get a pop-up. It's probably the easiest way to take it. It's just letting you know you're leaving our webinar software and you're going into CMS's Qualtrics survey software. It's not malicious. It's not spam. It's not taking you anywhere you don't want to go. Nothing dangerous. And just want to call out a couple of things that have happened based off of the feedback that you've given us. We have added chapters to our YouTube videos, our encores, so that it's easier to find key points in those sessions rather than having to scrub through an hour-long video. You can jump to just the pieces you want to see. We've also added training indicators to our live events page to help you more quickly identify the education that's going to be available to, or that's going to be of interest to you. And then also we have started offering our Medicare Education Expo. That is a full day event that is dedicated to one topic. In July, we did one that was specific to local and national coverage determinations. We do have one coming up in October. If you're newer to Medicare, we do have an entire day that's going to be dedicated to just Medicare, the basics, what it is from start to finish, the life of a claim, including a little bit about enrollment, because without going through enrollment, you can't bill a claim. That is available on our live events page, and Ashley provided that link. So I want to be cognizant of everybody's time. I know we went a little bit over. I want to thank you all for hanging out with us. I hope you found today useful. If there's something you would change, certainly please let me know that. But I want to thank you all for attending today. We're all so super busy and it's hard to carve out this hour, so I appreciate you doing that. On behalf of Ashley, Jennifer, Dr. V, and myself, and the entire Outreach and Education team here at WPS, I want to thank you for taking the time to join us today. I hope you continue to be well, have a great rest of your week, and you may now disconnect.